Hi everyone, welcome to my talk on penetrating myocardial injuries. This talk will help you identify these injuries, understand the pathophysiology, and provide an overview on management, both immediately as the patient arrives to the ED and later once they are more stable in the ICU and on discharge. The incidence and demographics of penetrating cardiac injury vary by country and region, though it typically accounts for less than 1% of all trauma presentations and occurs in men up to 8 times more than women. Penetrating injuries tend to be either caused by stab wounds or by gunshot wounds. The right ventricle is the most commonly injured structure due to its closer relation to the chest wall, the left ventricle being the second most common. The two main complications are cardiac tamponade resulting in cardiogenic shock, or hypovolemic shock from exsanguination externally or into the chest. The presentation of these patients focuses mainly on their hemodynamic status, which can vary from stable, shocked, in cardiac arrest, or dead. The main clue to trauma is signs of penetrating injury within the cardiac box, which is the area bounded by the nipples laterally, clavicle superiorly, and costal margin inferiorly. The commonest cause of shock or arrest is cardiac tamponade. In a pre-arrest patient, Beck's triad may be apparent: hypotension, distended neck veins, and muffled heart sounds. Dyspnea, tachycardia, and pulsus paradoxus are other sensitive features suggestive of tamponade. The FAST scan allows for rapid identification of pericardial effusion. Here is a subcostal view with the right ventricle anteriorly, the left ventricle, and a large area of hypoechoic material representing pericardial effusion. Also shown here is diastolic collapse of the right atrium and ventricle. IVC dilatation is another finding not present here. Although pericardiocentesis and subxiphoid pericardial window have been shown to accurately diagnose hemopericardium, these techniques are invasive and time-consuming, and are not typically performed in favor of a fast assessment followed by operative management if indicated. The standard ATLS protocol should be followed with attention to the ABCs. The airway should be secured with intubation and large bore IV access obtained. The patient should then be resuscitated with IV crystalloid initially, or blood products if hemorrhage is observed or suspected. An ED thoracotomy, or opening of the chest, is indicated in patients with penetrating chest trauma in cardiac arrest. It should not be attempted in arrests lasting over 10 minutes, in patients with any cardiac output, or in blunt trauma. The goal is to restore perfusion by evacuating pericardial blood or clot. So, how do we perform one? We start with bilateral thoracostomies at the 5th intercostal space midclavicular line, which are then connected with heavy scissor dissection. Retractors can then be used to open the clamshell, obtaining the view shown on the right. The pericardium is tented to protect the phrenic nerve, and incision is made to drain pericardial blood. It's important to note that mortality is reduced in patients undergoing operative theatre versus ED thoracotomy. Therefore, patients not in cardiac arrest showing fast scan signs of hemopericardium should be transferred to theatre as soon as possible for definitive management. The airway should initially be secured with rapid sequence induction and intubation. In shocked patients, ketamine is the induction agent of choice to prevent hemodynamic collapse. It is recommended to reduce or avoid adjunct induction agents for the same reason. Post-induction hypotension should be treated with volume resuscitation. Persistent hypotension and difficult ventilation should raise suspicion of a tension pneumothorax. One lung ventilation with double lumen endobronchial tube may be considered, allowing for collapse of the left lung and better surgical exposure. Anesthesia is maintained with a low-dose inhaled volatile agent, and arterial and venous pressures monitored invasively. Techniques for operative repair or cardiography include skin staples or sutures. Staples are easy to use but better suited for linear lacerations in ventricles, while sutures offer greater control but may be more challenging in a beating and exsanguinating heart. A Foley catheter can be used for hemorrhage control. Wounds near coronary vessels are repaired by horizontal mattress suture through myocardium beneath arteries to prevent vessel injury. care should be taken to ligate any small coronary branches that may have been transected as a result of injury to prevent post-operative reaccumulation of pericardial fluid. To prevent sutures cutting through damaged myocardium, sutures are combined with pericardial baffles as shown. In defects that cannot be approximated, cardiopulmonary bypass should be established with consideration of ventricular prosthesis. Immediate management in the ICU post-damage control surgery will involve continued resuscitation and physiologic support. Shock should be treated with intravascular fluids to maintain or improve microvascular perfusion. Respiratory support involves adequate oxygen delivery and ventilation without worsening hemodynamic stability. Hemostasis should be continually reassessed to prevent coagulopathy, especially in the setting of aggressive volume resuscitation. Development of hypothermia is a noted post-resuscitation phenomenon in trauma and can worsen coagulopathy and dysrhythmias, both of which our patient is at increased risk of at present. Sequelae of penetrating injury can be divided into perioperative and delayed. Perioperative include bleeding, acute cardiac failure, post-ischemic myocardial dysfunction, and missed cardiac injury. Other intracardiac injuries sustained at the time of trauma may initially be asymptomatic, and delayed presentation was common. Delayed sequelae occur in up to 80% of post-traumatic cardiac injury. They include atrial or ventricular septal defects, valvular dysfunction, ventricular aneurysm with mural thrombus, and recurrent pericarditis. Follow-up should involve ECG, echocardiogram, and consideration of cardiac catheterization. Thank you very much.